Jumping into MRI of the hip, generally what I like doing on this is just kind of sequence by sequence, kind of just working my way through the study. As you can see, it's kind of a multi-planar study with several T1 and fluid sensitive sequences. So starting with the localizer, what's going to be really important here is to evaluate the portions that are not going to be included in the field of view on the additional sequences. So mainly seeing if portions of the liver or kidneys drop down, making sure there's no mass lesion there, as well as in the proximal thighs, or if there are portions of the reproductive system, mainly being the scrotum. Is there an undescended testicle? Is there an obvious epididymal cyst or testicular mass that you see? In this case, really not really seeing anything. Next, we essentially will have two large field of view sequences, one being a non-fat suppressed T1 and the additional sequence being a fluid sensitive fat suppressed sequence. So really what I like doing here is first eliminating findings from the soft tissue structures in the pelvis. So looking at the rectum, making sure there's no mass or inflammatory change. Looking at the bladder, making sure there's no mass as well, and taking a look at the reproductive organs to see if there are any incidental findings. Outside of that, I take a close look at the marrow signal. This is just kind of a non-specific heterogeneous appearance of the marrow that is likely related to islands of underlying red marrow that are left over in this patient. So looking at the femoral head, neck, proximal femur bilaterally, looking at the pubic symphysis and the superior inferior pubic rami, and then the iliac crest coming into the sacrum in a portion of the lumbosacral spine here. And we're essentially going to be doing the same thing on this fluid-sensitive fat-suppressed large field of view sequence, looking for abnormal marrow edema involving the proximal femoral head or femoral head-neck junction, and looking into the pubic rami, making sure there's no fracture deformity or abnormal marrow edema coming along the sacroiliac joints. You want to pay special attention to the sacrum, especially in older patients, as sacral insufficiency fractures can be easily missed on these studies. As long as you're making sure it's a part of your checklist, it's one of the findings you won't miss on these studies. Sometimes you can also see prominent lumbosacral degenerative changes with either fatty or edematous degenerative end plate changes. And then I do take another look at those soft tissue structures in the pelvis. No bladder mass, taking a look at the prostate gland here, making sure, is it enlarged in size? Is there BPH? Don't really see anything. And for the rectosigmoid colon as well, which looks okay in this case as well. Then we get our final large field of view sequence here. I do take another look at all of those soft tissue structures in the pelvis, looking at the bladder, looking at the prostate gland, looking at the rectum here, which all look okay. And then essentially what you want to do, it's easy to kind of run several structures several times. This is a study that's dedicated to the left hip, so we're going to get smaller field of view images that have a better view of a lot of the structures on the left side. However, the contralateral side is not going to be included. So what I tend to focus on is the side that does not have the dedicated small field of view sequences. You can essentially kind of run these structures in a clockwise or counterclockwise fashion, but we'll get into a little bit more detail of those structures on the smaller field of view where it's easier to see those structures. This axial T1 oblique sequence is used to really kind of evaluate the junction of the femoral head and neck to see if there maybe is cam-type morphology or an osseous excrescence here, which can contribute to a femoral-acetabular type impingement, whether it's pincer or cam-type morphology, which can predispose patients to having labral abnormalities. So this is really going to be kind of the workhorse of the study, where we're going to be able to take a really good look at a lot of the tendons, muscles, and soft tissue structures about the hip joint. So I like starting with the iliopsoas tendon, which is going to be a conglomeration of the psoas and the iliacus, which will converge to form this tendon. And then as we follow it distally, it'll insert on the lesser trochanter. Then we come into these structures up here. The one that is more superficial is going to be sartorius, and it comes from the anterior superior iliac spine. A way to remember this is it involves a lot of S's: sartorius, superficial, superior iliac spine. Deep to that is going to be your rectus femoris, which comes off of the anterior inferior iliac spine. And as we come out to here, you can see sartorius, rectus femoris, and the structure lateral to it is going to be your tensor fascia lata, which has an L in it, an easier way to remember that it's a more lateral structure. And then we're going to come into our gluteal musculature. You can see that there are two different muscle tendons here. This is going to be our gluteus minimus. This is going to be our gluteus medius. And essentially, the minimus is going to insert on the more anterior facet of the greater trochanter, and the medius inserts on both the posterior and lateral facets of the greater trochanter. This is a common site of pathology for a lot of patients, so you really want to gauge, is there tendinosis? If there's tendinosis, is it mild, moderate, severe? You're looking for the thickness, how much amorphous or intermediate signal is within the tendon, and once you start getting fluid signal, you can maybe start describing interstitial tearing, which could progress to potentially even a full thickness tear of both minimus and medius as we come out here. The other thing you can comment on is the degree of greater trochanteric bursal fluid, and these large field of view images can be kind of helpful to see if there's asymmetry in that fluid as you're comparing the left side to the right side to suggest if there's true greater trochanteric bursitis. After that, we come a little bit more posteriorly. These are going to be the proximal hamstrings, which will go to the ischial tuberosity. This is actually a conjoined tendon where three muscles are going to be contributing to this proximal origin of the conjoined tendons. This tends to have a little bit more heterogeneous signal proximally, so you want to adjust your threshold for calling an abnormality with the proximal hamstrings. This commonly will also have some underlying marrow edema in the ischial tuberosity in some cases. Another common thing that you may see in these cases is edema in this space right here, which will be quadratus femoris musculature edema, which is something that can suggest ischiofemoral impingement. Going back to the gluteal tendons, for the particularly bad cases where there's full thickness tearing with hematomas and fluid, it can also be important to look at the sciatic nerve to see if there's signal alteration or morphological changes. You can see the sciatic nerve kind of where my cursor is here, and you can actually pretty well visualize it in a majority of these studies. As we're kind of scrolling up and more proximally here, it looks normal in signal. There's really not a lot of signal alteration with the sciatic nerve. And briefly, just kind of talking about some of the adductor muscles. These can be a little difficult to discern which one is which. What you can confidently identify is think of it as kind of more superior structures versus more inferior structures. As you're more superior, one of the very first muscles that will pop into view is the pectineus. As you go inferior to that, you're really going to have a conglomeration of your adductor brevis and longus. And as you go more inferior, adductor brevis and longus become less conspicuous, and you start to get into your adductor magnus. And you can even see a little bit of the gracilis muscle start here as well along the medial aspect of the proximal thigh. So those are the main structures that you're really going to kind of evaluate pretty well on this small field of view. And now the sagittal is going to be particularly very important to evaluate the labrum on a majority of these cases, even at non-arthrographic technique. The portion of the labrum that tends to be abnormal most often is going to be the anterior superior aspect of the labrum. The labrum should be a contiguous black structure, and you can see here, it looks like there's a little fragment of the labrum that is discontinuous, detached, and there's some blunting with signal abnormality along the anterior superior aspect of the labrum, reflecting a labral abnormality. The other thing to look for is if there are large cysts adjacent to the labrum. These paralabral cysts can be an additional indicator that there's underlying labral abnormalities, tearing, or degeneration. This is also the portion of the hip and the sequence where you'll take a very good look at the cartilage. And so you're essentially going to have the femoral head cartilage and you're going to have your acetabular cartilage. And the portion of the cartilage that tends to also become abnormal first is kind of this anterior superior cartilage. You can see these portions of the cartilage look relatively homogeneous in appearance, but as we start to get next to this labral abnormality, there's a little bit of heterogeneity and surface irregularity of the superior acetabular cartilage. The other thing I like using the sequence for is a tiebreaker for when you're not really sure what's going on with the gluteus minimus and medius musculature. As you come out more laterally, you can actually see the tendons pretty well as they're inserting on the more anterior portion of the greater trochanter, so this being minimus, and the more posterior portion of the greater trochanter being medius. Minimus, medius. And then usually what I like using the coronal for, this is kind of a more conventional way to look at the hip kind of straight on as if you were looking at a radiograph to see the degree of how much cartilage loss is there. Is there a lot of osteophytosis? Is there prominent subchondral cystic change or marrow edema? And this can be helpful for cases of avascular necrosis, potentially to see, is there subchondral collapse of the actual femoral head itself? Outside of that, this can be used to troubleshoot looking at the soft tissues, tendons, and muscles about the hip if there were any concerns on the other sequences.